Yeah.
Good evening, everyone. This is Dr. Satya Yadav. On behalf of Society for Pediatric Cell Therapy and Transplant, I welcome you to the 11th webinar. And this time we have a very, very important topic relevant to India, that is preparation for transplants for hemoglobinopathies. And as you know, thalassemia is like one of the topmost indications for allo transplants in India. So we need to know all about this. And we have a great speaker who is well known in hemoglobinopathies field. So, and to introduce the speaker, we have a session being chaired by Dr. Shailesh Kanvinde. So, Dr. Shailesh Kanvinde is head of pediatric hematology, oncology, and bone marrow transplant department at Dinanath Mangeshkar Hospital in Pune, and he has trained in Tata Hospital, Mumbai, in pediatric hemonc. So Sailesh has been a friend for a long time, and I will invite Sailesh to take over the proceedings and introduce the speaker, and later on take up the questions in the chat box and share it with the speaker. Thank you, Sailesh.
Thanks, Satya. It's a great honor to be here. So it's my honor to introduce the speaker today. She's Dr. Shalini Shinoy, who is the professor of pediatrics and the Teresa Vietti Scholar in Pediatrics at the Washington University and the St. Louis Children's Hospital. She also has been the medical director of stem cell transplantation and cellular therapies at St. Louis from 2007 to 2024, and has also held leadership positions in various hematology and transplant organizations like ASH, COG, and ASTCT. Her research focus has been on BMT for non-malignant disorders, and we're going to hear from her regarding hemoglobinopathies. She has also worked on reduction in transplant toxicities and use of non-TBI regimens, long-term follow-up of children who have undergone transplantation, and so on. She has a considerable record in this field and has more than 100 publications to her credit. So I invite Dr. Shalini to begin her talk on preparation for transplantation. Over to you, Dr. Shalini.
Thank you. Thank you so much. You can all see my screen now, right?
Yes, it's
fine. Yes, it's fine.
Okay. So I'm going to talk about the preparation, and I will start off full disclosure. We see more sickle cell disease than we see thalassemia out here. So a lot of my practice, I would say 3/4 is sickle cell disease, 1/4 is thalassemia, but I think the preparation sort of overlaps between the two. So hopefully it'll be relevant, and I'm looking forward to the discussion after this so that we can both, share information and learn more. Let's see. Moving my screen. Screen isn't moving.
You could just click once, Dr. Shalini, and then click in the center. Yeah, now it's moving.
Okay, here we go.
Yeah, now it's fine. Yeah.
So I'm going to start off with a case that we dealt with recently, and sort of going through the problems that we face. And I know that our problems are a little different, but I think some of them would be very relevant. So he was 17 when he was referred to us for curative therapy. He was referred by the hemoglobinopathy group that treats conservatively all our patients. And his sickle cell history was relevant for worsening MRI. He had silent strokes. He had unremitting pain despite hydroxyurea. He had a poor quality of life. He had needed multiple transfusions in the past. He had failed crisanlizumab. So they really didn't know where to go with him. And his home pain control constantly included methadone with oxycodone that was very frequent in use. And then he was always in the hospital, which his treatment included Dilaudid and prolonged patient-controlled analgesia. He had excellent family support, but he really wasn't able to control his pain. And so his other history, which also was what they were dealing with, was he had eosinophilic esophagitis that had been pretty symptomatic over a few years. He had an anxiety disorder, and I don't blame him because his quality of life was so bad and he didn't know when the pain was going to come next. He had intractable migraine, possibly because of all the anxiety as well. He also reacted really badly to vaccinations. So he got the flu vaccine, which we get every year here because the flu, it gets really bad. And he reacted badly to that, never took it later. And then he had a deep vein thrombosis that he developed probably during one of his pain episodes. He was on apixaban for the same. His family history, his father had renal failure, he was hypertensive, and the mother had autoimmune disease. Of course, both had sickle trait, but they also had other manifestations. He was hyperactive with Benadryl, so Benadryl was a no-no. And the medications that he had tried Dupixent for the eosinophilic esophagitis. He reacted to that. He was on oral budesonide. He was on Botox for migraine. So he was like a walking pharmacy when he came to us. There were meds that he had done that were too complex for his age of 17 years. So the labs, his labs, were what you would expect. His hemoglobin ranged between 7 and 8 grams. His other counts were normal. His bili, of course, was high. And he was G6PD deficient. So he had an additional reason, I guess, for hemolysis. He had albuminuria, and his albumin creatinine ratio was already 200. His heart, there was some evidence of the chronic anemia. His ejection fraction was 35%. He had no HLA antibodies, which was a blessing, but he was alloimmunized for red cells. He had anti-JKB and anti-S. And we didn't check his immunization titers. His history was so spotty that we didn't do that. And then his head MRI showed silent strokes, and his neurocognitive assessment showed that he already had processing speed delay even at this young age. And just quickly, his course, we gave him rituximab for 4 doses. His hemoglobin S percent was brought down to 18% with very specialized blood, which was antigen negative on day 22, which is when we actually start our conditioning. His donor, he landed up getting a mismatched unrelated donor because neither of his parents were really good donors based on their own disease. And it was red cell reduced due to the presence of JKB. He was a B allele mismatch transplant. He got a reduced intensity conditioning, and he got GVHD prophylaxis with tacro, short course methotrexate, and abatacept. And then he developed significant hypertension with tacrolimus. So we had to discontinue the tacrolimus pretty early, within 1 month of transplant. And then he also required 3-drug hypertension control even after we took the tacrolimus away. The tacro just made it worse, and so we weren't able to keep that going. His GVHD prophylaxis ultimately became belumosudil and abatacept, believe it or not. He was one of those outliers. Didn't tolerate sirolimus. He didn't tolerate Jakafi. And he developed some skin GVHD. Luckily, no other GVHD was noted, and it responded to UVB therapy and got better. So then he came back with a dog bite, which got infected with Pseudomonas and VRE, required long-term linezolid and cefepime for about 6 weeks because of osteomyelitis after the bite. But then now he's 1.5 years out, resuming immunizations and doing okay. But he spent a lot of time in the hospital trying to get over, and not just his disease, but also all the complications that he had. Still has EOE, still on budesonide, but under fairly good control. That's just to give you an idea about how my team is really worried when a patient with hemoglobinopathy comes to transplant, because they know there's going to be a lot of other things that they're going to have to deal with. And I tried to put some of them together in this here. The top one, the symptoms, are probably the simplest. We know what all can be affected. We know that the thalassemia patients require chronic transfusions, have a poor quality of life. It's a cost drain throughout lifetime. And so if they have a sibling who either has a trait, we would offer them transplant straight away, whether they have sickle cell disease or thalassemia, so they don't need to have the symptoms. Now, if you're going with a haplo or an alternate donor, we would expect them to be symptomatic, only because of the higher risks that we are taking and the longer duration of care that they will need. And they have to be on board that the transplant is going to be something they want to do. And then, of course, we would optimize organ functions, which I think we're going to be talking about later. But one of the big things is the iron overload that they usually come with. And optimization can take several months. We take our time. It may take up to 6 to 8 months. But we make sure that we bring down their iron load so that we don't give them extra problems. And it becomes an issue if they live far away. So you have to work with somebody who is elsewhere and track the patient and then bring them over when they're ready for their transplant. The things that we find a little harder and that we work hard on is, one, psychosocial health. Even though they want the transplant, there's a lot of anxiety, and rightly so, because of all the dangers that might come with the transplant. And one of the things we sit down and talk to them about is compliance, because especially in a 17-year-old like this child, compliance becomes an issue when they're feeling good. And they're feeling good because you're giving them the medications to make them feel good. And if they stop it, they're going to have a problem. And so we talk a lot about it. And we also talk about support. We can't make them take their medicines, right? If a 3-year-old or a 4-year-old, the mother can probably sit there and watch them take it. A 17-year-old is not going to listen to that, so they have to accept responsibility on their own. So a lot of education goes into that. And then we also warn them that it's not like you get a transplant and you're fine the next day. You really have to give us 1 year of your time if you're a sibling transplant, and 2 years of your time if you are but think about the long term. You're going to be disease free, but you really have to be under medical care, good medical care for that period of time. And then we make arrangements for school or work so that they can get their time off, and so that the family support has some time off to help them take care of themselves. So the reason to go to transplant, I don't have to tell you, right? They in sickle cell disease, despite transfusions, they run the risk of developing manifestations. The pain is improved with transfusions, but many of them will develop a second CNS event even when on transfusion therapy, as the graph shows you here. The cost and the availability of transfusions become an issue, and the quality of life going in once a month or once in 3 weeks to do that becomes a big issue. Red cell alloimmunization, it's a bigger risk with sickle cell disease than it is with thalassemia. And thalassemia has been published as anywhere between 10 and 20%. I'm not quite sure how many you see. India seems to have less alloimmunization than the Middle East, for example. But it's not unknown, and that could cause an extra layer of transfusion difficulty in these patients as time goes along. And even for transplant, it is a problem. So if you're going to transplant them, best to do it before they get alloimmunized. And then if you look at the kind of alloimmunization antigens, I'm not going to go through the list, but what this is the top part tells you how many of the donors are positive for a particular antigen and how many of the recipients, and this is for African Americans specifically, but extended phenotype match blood is better to give to prevent alloimmunization. And the extended phenotyping we do is for CE, KEL, Duffy, and KID. The most common antibody seen, thalassemia or sickle cell disease, is really KEL. But Rh antigens and then the JKA and JKB are also quite prevalent, which can lead to hemolysis just with transfusions and also hemolysis post transplant. So in terms of donor selection, the first thing, of course, that all of us would do is HLA typing and determine which donors could be eligible. The next thing we pay attention to is the CMV status. We would like not to expose them to CMV if they are CMV negative. We would like a CMV positive donor. If they already have been exposed to CMV, knowing that it is probably going to become a problem somewhere along the way. A younger donor is much better. A blood type match donor is great. Note there's no trait consideration, and we also don't consider the Duffy null or CBC because we don't have the luxury. You know, once you cross the HLA and the CMV, you're pretty much down probably to one donor at best. And then the next thing we want to do is see if your donor is a sibling. We'd like for them to be over 3 years of age because you don't want to, harvest a donor that is really young. Even 3 years is pushing it, and a lot of ethics committees have trouble with this. But I think beyond at that time, we usually have better permissions. If it's a MUD or mismatched recipient, a donor, then we offer those to our patients that are less than 13 years of age because they do better. If they're haplo, we go for the haplo if they're older or if they're larger, because getting an unrelated donor and getting the right number of cells and so on becomes more difficult. Now, for stem cell source, umbilical cord blood is only applicable to the young recipient because expanded cords are super expensive and they do have a risk for GVHD. We ask for marrow if the cell dose is feasible, if the donor is large and the recipient is smaller, but if they are pretty much the same or the recipient is larger, then we go for PBSCs, but we don't infuse PBSCs on the whole. We do a CD34 selected with a T-cell add back of 1 million cells. We found that they tolerated quite well and their GVHD risk as well as their chronic GVHD risk comes down, especially with the current GVHD therapy. We usually don't have to worry about chronic GVHD in these cases, or if we do, it's pretty localized. And then the haplo source, younger the better. So if there is a sibling, that would be preferable. A lot of them don't have old enough siblings since we're all pediatrics. The medical and medication history in the recipient becomes important. We don't consider the parity or the sex because we really, it would be nice, but we don't have the luxury of doing that. And a lot of what we do, it goes by what we anticipate are the risks. And the top graph here shows you that graft failure is a issue if you have a mismatched donor or if you have a unrelated donor, so a haplo or an unrelated mismatch, especially in the young. And in the older patients, GVHD, mortality, and graft failure are risks. This was the old data, and obviously all of us, including you all, have worked on this to mitigate some of these risks. So what are the changes that have been made? So conditioning, the pre-transplant immune suppression that is done in different ways has certainly improved engraftment. Conditioning regimen have been modified accordingly to make them less toxic. We use reduced intensity, but we also stand by for stem cell infusion if need be after. The donor source cell selection has been a big blessing for us. Expansion, of course, may catch up in the future as it becomes cheaper and it becomes more applicable. The one that is approved here is the nicotinamide-based expansion. The GVHD prophylaxis, I think the two big drugs, we use a lot of abatacept, but the post-transplant cyclophosphamide, as you know, has made such a big difference. So I think GVHD is much less of a scourge now than it used to be. Infection prophylaxis has come a long way. And for those of us that are lucky enough to also get antiviral cytotoxic T lymphocytes, those are acceptable. They are tolerated very well. And then chelation mechanisms. You can do multiple chelation agents. You can hypertransfuse and you can tackle organomegaly. And luckily, you have a non-malignant disorder, so you have time. There's no reason to rush, and you can bring your patient to a better status before you transplant them. So the extended red cell phenotyping is done in our donor so that we know what to expect, especially if the recipient is alloimmunized. The recipient is genotyped because of all the blood they've been exposed to, whereas the donor, it's cheaper, is phenotyped to make sure we know what their typing is. And then if I told you we just need to be aware if they are Duffy null that their neutrophil count is going to be low, that it's not going to cause them a problem after engraftment. One of the big things is if they have associated alpha thalassemia or beta thalassemia trait, they're going to have a low MCV. And once they leave your center and they go elsewhere, they need to know that their MCV is always going to be low, because someone's going to look at them going, oh, we have got an iron deficiency here, and it's important to remember that. There seems to be no value in assessing anti-HLA antibodies in the donor. We don't do that. And then for the donor, we, think about anesthesia risks, their weight, what are the issues with donation that they might come across, make sure they have no active infections or immune disorders, and they do consent if they're over 7 years of age. So most of our haplotransplants, automatic consent, are mat sibling donors. If they're over 7, they consent as well. And then psychosocial support to the donors. We spend a lot of time with them so that they're not super worried about what their cells might do or might not do in the recipient. So for the recipient, the standard organ functions I've listed here, and then some of the things that we pay attention to that we like to do, especially since if you're a hemoglobinopathy center, the albumin creatinine ratio before and after transplant is important, as are pulmonary function tests and care of reactive airway disease, because you don't want to put them, compromise them, and you want to be able to track it after transplant. Now, age-appropriate neurocognitive function is something we do pre-transplant and then track after, because this is where, what you expose them to could make a difference, and we try to track it to make sure we leave them pretty intact. We also do a pitted red cell count for spleen function and then track that as well, especially if the spleen is intact in these patients. The one thing that I would like to point out is infection. We routinely, and I'm sure you all routinely do like a CMV test to see if they're CMV positive. Some of the things that we found a problem are things like sinusitis and dental caries. So very careful assessment of any infection that they might have that needs to be eradicated before transplant becomes an important issue. And this is very sickle cell disease specific, but they're very prone to hypertension and their baseline blood pressures are lower. And so we follow, there's a chart all over the transplant floor that tells us what is the 90th percentile of systolic blood pressure for these patients. And we don't let their blood pressure go above that at any cost. The problems are press. The problems are also hemorrhage, cerebral hemorrhage because of cerebral vasculopathy. Just a word on alloimmunization. So we do give rituximab preconditioning if they're alloimmunized, whether it's HLA antibodies or whether it's red cell antibodies. And then we hope that the serotherapy that comes with the transplant can also downregulate this further. Antigen negative transfusions, we avoid steroids just because steroids are an infection risk in all hemoglobinopathies and of course a press risk. And then donor product manipulation, of course, if they have a major or a minor mismatch, depending on what needs to be done to the donor. Now, there are reports of people using bortezomib and daratumumab. We try to stay away from the highly immune suppressive agents. And plasmapheresis can be done, but it's, of course, a temporary block. And then for the anti-donor HLA antibodies, we know that if they're over 5,000 MFI, that's really a very high risk for a unsuccessful transplant. And if they're between 2,000 and 5,000, they have poor graft function. So we like to bring them to less than that before they come to transplant to improve outcomes in all these patients. The other thing is kidney. The problem that we have with the kidney, not just hypertension, but also glomerulopathy, because a lot of the medications we give them are nephrotoxic. And so sepsis medications, the presence of veno-occlusive disease, renal infections such as BK, all add to their kidney problems. And we try to be as proactive as possible to try to protect the kidney and not expose them to multiple nephrotoxic agents all at the same time. If they do land up on dialysis, though the risks have improved now, dialysis is easier, it is expensive, and the mortality still remains high after several years. And one of the things to be aware of is that if your albumin creatinine ratio, the higher it is, the more the risk of mortality from kidney disease. And it's always nicer to make sure that the kidneys are well protected. For as far as the liver goes, for the iron concentration, we like to bring it to under 8 and make it more of a mild iron deposition before we take them to transplant. A word about biopsy. So we've given up on liver biopsies now because we try to keep their iron lower. And in pediatrics, it's uncommon to see cirrhosis. But if you're suspecting cirrhosis and they have impaired or liver function tests, then a biopsy is the only way you're going to find the cirrhosis. So I would say that the outliers should certainly consider that biopsy, especially if they have infection and cirrhosis you think is an issue, or they have the idiopathic cirrhosis that children get depending on their origins. So our anticipatory guidelines, our hemoglobin S needs to be less than 30% prior to starting, either with manual exchange transfusions or with serial exchange. If you have a thalassemia, you're going to hypertransfuse them to decrease their extramedullary hematopoiesis, to bring that under better control and to manage your organomegalies better. We like to bring the ferritin to less than 1,000 nanograms per mil, even though it's not a definite correlation. It can increase with infections and so on. We like to keep it less than the 1,000. And then the other thing we warn them is no vaping or smoking. I'm not sure how common smoking is in children in your practices, but over here, the vaping has become a huge deal. We warn them not to smoke through the period of recovery from transplant, and if possible, never. I don't know if they ever listen to us long term. And no secondhand smoke. We warn the families as well. And of course, we have the follow-up that is needed from our other specialists, depending on what their morbidity might be. The press risk, whether it's thalassemia or sickle cell disease, ranges between 20 and 34%. So to maintain a TACRO level that is low is our goal. Even though a normal range is up to 15 nanograms per mil, we maintain our TACRO 5 to 8 if they are getting TACRO. We don't let it go above 8. We avoid steroids, and if we need to give steroids for any reason, we like to keep it less than 1 milligram per kilo, and then monitor for hypertension, avoid it at all costs. Maintain hemoglobin 9 to 11 for our sickle cell patients, 10 to 13 for the thalassemia patients. And of course, now you can try to avoid tacro or steroids with the alpha beta TCR CD19 depleted grafts. They are expensive to do, but also the immune reconstitution in these patients takes a really long time. So to be aware that they could be at infection risk for a longer time, and they have to be monitored. So you trade off one for the other, but there are ways of trying to see which one you want to avoid more. We also keep them on anticonvulsants till they are off most of their medications, especially the calcineurin inhibitors. Then medications to try to avoid, as you know, think of the side effects of these medications. Again, cyclovir, the azoles, linezolid for bone marrow suppression. One thing I want to stress is that we avoid fluid overload. Their heart is already under strain. They can develop veno-occlusive disease, and so careful fluid management becomes really important in these patients. And if they are post-busulfan, they need to be monitored really carefully, both clinically and by imaging if need be. I won't go into those details because it'll take too long. And then infection prophylaxis and monitoring for as long as they're immune incompetent, depending on how you chose to transplant them. We do offer them ova, ovarian tissue, sperm, testicular tissue. They do need to understand that you're propagating the abnormality if they go for cryopreservation, but we make sure we tell them and do whatever they want to do. Hyperviscosity is an issue with SED. So even though fluid balance is managed really carefully, we have to make sure they don't get dehydrated, because then that leads to thrombosis. We also make sure that antigen negative blood is available to tide them over. So the blood bank will get blood and store it for use for the whole year. They will freeze the blood for the whole year if they can do it. That would be easier in patients that are really hard to transfuse. Antibodies against non-ABO antigens are a high risk for graft rejection, and that can be true despite rituximab. And more recently, one of our the STAR registry that we do here for pediatric patients has shown that their risk for GVHD is also higher if they have non-ABO antigens. It's going to come out soon. He's working on publishing that. We keep the platelets over 50,000 to prevent vasculopathy-related hemorrhage. And if they are past thrombosis patients, we hold their anticoagulants when they are thrombocytopenic, like they have a platelet count that hasn't engrafted yet, and we resume it after platelet engraftment. So we take it down once their conditioning is done, once their platelets drop. And then some of the special circumstances we've come across is you got to prepare the donor. The donor may be iron deficient. The donor may have other problems. Make sure the donor is in good health. Infection and iron deficiency are our biggest problems. If the donor is on contraindicated medicines, check to see if they can hold it prior to collection. May or may not be safe enough. If the recipient has G6PD deficiency, there's a lot of medications you want to avoid that you might use during transplant. Some of them are listed here. G-CSF is okay to use post-transplant, even in sickle cell disease. G-CSF is not a problem in your thalassemia patients. And rarely, if they have PRES, you're going to have to take them off tacro, cyclosporin, and sirolimus and find alternate GVHD prophylaxis in these patients. A lot of psychosocial support, like family support, and these are harder to do. These are, it's easier to work with the medical part. We know the data. These are things that we have to go back to the schooling, this family support, the travel support, and realistic expectations from the family as to when they need to come. Make sure you keep appointments. You need to come if there's an unexpected course. These are things we try to pre-prepare them before they even come to transplant. I already mentioned some of this. I don't think I need to go into these details, but these are things that I think as the planning is going on, what kind of conditioning, what kind of pre-transplant immune suppression, where's the red cell alloimmunization, where are the HLA antibodies, and very importantly, post-transplant immunization and then following titers is very important after they're off immune suppression. And then we take the sickle cell patients off penicillin when their pneumococcal vaccination is completed and they've developed pneumococcal titers, knowing that their splenic function only recovers if they are young. The older patients never recover splenic function. So to do all that, it takes a whole team. I've sort of listed the village here that we depend on to do the different pieces of bringing a patient to transplant. And with that, I will end and we can go on to the discussion. I can stop sharing my screen. And thank you for listening me out.
Yeah. Thank you, Dr. Shalini. That was a very informative talk. Let's see if there are any questions in the chat box.
So before we have questions, I would like to ask one question to Shalini. So the first case which you started, 17-year-old. So you have rightly highlighted that psychosocial issues are also something very important. And do you routinely do psychiatric assessment for your teenage patients or any psychosocial evaluation before transplant? Thank you.
Yeah, that's a great question. We have them meet the psychologist and have a chat with the psychologist. And the trick there is some patients respond better to females and some respond better to male psychologists. And so we try to match them depending on their preference. And then we keep them involved through the period of transplant so that they already know a person if something, they come in for an infection and they didn't expect to, and they're totally bummed. It's nicer to have a psychologist on board throughout the course of the transplant, which we do.
Because we have had few patients who went in depression after transplant, teenage girl, and she had BK virus induced hemorrhagic cystitis, a lot of pain and everything, and then she had to be treated with the help of a psychiatrist, and that was needed. So
Yeah.
I think that's an important point.
Yeah,
And
very true. And the hope would be to try to keep them off medications, but sometimes it's just impossible. And yeah, you're right. A lot of some of our patients will land up on antidepressants too.
Can I ask one question?
Mm-hmm.
Yeah, hi. Thank you,
Hi,
Shalini,
yeah.
for a fantastic presentation. Gaurav this side. So I wanted to ask about you briefly mentioned about your fertility preservation strategy. So in males, obviously, it's a bit easier. But in females, how will you sort of compare your oocyte cryopreservation vis-a-vis your ovarian sort of cryopreservation? So what is the strategy which you are adopting? And second question in this context is, how often do you see like either ovarian failure or sort of azoospermia or oligospermia in young, very symptomatic sickle cell disease patients?
So both are really good questions. So to store either the sperm, ova, or tissue, it's a cost. And they actually have to pay a cost every year. The collection is covered by one of our philanthropic organizations. And we usually collect it when they are under general anesthesia for their line. So we're not doing a separate procedure on them. they, depending on age, they decide if it's a oocyte collection, it takes a little longer because you have to wait till they ovulate, and OBGYN helps us to collect those oocytes, but definitely, something that's less invasive than putting ovarian tissue away. Otherwise, they just resect an ovary and they freeze it if the children are young enough. They do collect testicular tissue and freeze it if the patients are younger and they cannot produce sperm. And the issue with fertility is twofold. If they are on chronic transfusion therapy and they have iron overload, they already come to us with poor ovarian and poor testicular function. And even if they try to collect the sperm, it's not really successful in a lot of these patients. Add the transplant to that, and it depends on what you expose them to. The reduced intensity, of course, is better, but if you have pre-transplant immune suppression, or you have radiation, or you have busulfan, I think you tend to make that a little worse. So almost, I would say, in our hands, almost 30 to 40% of them they have to expect to have poor fertility at the end of the transplant. And so we ask them how interested they are in making sure that some of this is frozen before. Now, have I seen successful ovary implantation? I know it has been done, but none of our patients have ever come to that or asked for it. We have it frozen, but I can't tell you, about successes, at least in our hands.
Thank you, Shalini. So we have a question in the chat box. Dr. Dhwani Thakkar is asking that what is the dose of rituximab you use in your patients?
The standard, it's 375 milligrams per meter squared that we use, for other indications, and we do 4 doses of it once a week. Sunil?
Okay, Dr. Shalini, I have
No,
a
I
question.
think you answered that question. My question was to ask you actually, how successful, we almost for the last 15 years, when I was in Sydney, we used to do ovarian tissue cryopreservation. Testicular, we started a little later, but I've not seen still a successful pregnancy, around me. In our experience, of course, none, but also around me or the previous centers we worked in. So I'm not very sure, because always, getting a tissue out is always, as you said, money also, but also the effort in it, and also the ongoing cost of preservation. So I'm not sure what to tell the parents, when they ask for it. Oocyte and sperm preparation was okay, but the tissue preservation, I'm not pretty sure, what to say. I want to ask you whether have you seen any successful pregnancies?
I know that they've done ovarian implantation successfully, not for our transplant patients, but for other, they have used it and it has been successful. I actually have a nurse practitioner who works with me now who had Hodgkin's disease when she was younger and had ovarian implantation after, and had successful pregnancies. So OBGYN is very, very confident about its success. I think the issue with sickle cell, I worry about the gene is going to be transmitted, right? Whether it's thalassemia or sickle cell, it is going to be genetically impaired. But no patient has come forward. Now, they've had children on their own when they haven't had a problem post-transplant, but nobody's come forward to use the tissue that we have, not yet.
The second, the comment which Dr. Yadav asked a very important question, and Dr. Ria is also on the call, and she heads our psych-oncology unit. And we see it. Before, I think we were not even picking them up. It was just the tip of the iceberg. But now every patient goes through them as a part of the pre-transplant kind of pathway evaluation, and then they follow them up. It's pretty common. It's very common. I mean, some of them may go on to medications, but then most of them will require significant support throughout, before and through the transplants, including the caretakers. I think it's very much important aspect of this. Thank you. Back to Shailesh, please. Sorry, I took your time.
Now, just one question, Dr. Shalini. You mentioned that you're not doing liver biopsies now as a part of the pre-transplant workup. Do you have any experience with the non-invasive techniques like the liver elastography or the fibroscan?
Yeah, I didn't mention those, but we try to do that if there is suspicion for VOD, then elastography is something we resort to, but only in the presence of symptoms. This is during transplant that we do that. Elastography is not done as a pre-transplant workup. We don't do it. I think what we rely on is the MRI. You know, we just do the T2 star MRI. If it's a TAL patient, we do both the heart and the liver. If it's a sickle cell patient, we just do the liver. And then try to bring the iron level down before we take them. Cirrhosis is so rare that if their LFTs are okay, we don't put them through a liver biopsy anymore. We used to, but we don't do that anymore.
Dr. Shalini, may I ask one more question actually? So
Yeah,
with respect to the radiation and the agents which actually lead to might interfere with the fertility. So basically, there are different strategies, and when it comes to alternate donor transplant, especially haplos, most of the centers use either 2 grades or 4 grades radiation. Now, quite a number of times we tell our physicist and radiotherapy consultant that we would like to preserve the testis as much as possible. And unlike malignant diseases where they're worried about the hotspots, it's not the case with the benign disease. So if it's a little bit, not to that extent perfect radiation, then also it doesn't make a difference. But with that strategies of 2 or 4 grays with ovarian protection, ovary or sperm, testicular protection, what is your experience about the fertility preservation over a long period of time? I mean, not in the malignant, non-malignant settings, but 2 or 3 of my malignant transplants who underwent a typical sort of 2 grays based conditioning for different indications. So they have fortunately been able to conceive. So I wanted but that's a very small experience, just 2 or 3 odd patients. But what's your experience about it?
Well, just like you, we offer them preservation because we are not quite sure. Now you're giving them also other therapy, right? It's not just the radiation that is the problem. So we don't ever, we always warn them that fertility could become a problem. And do they want to use that option? So, and almost always they want to. And so we do that to tell them that you don't need to because this is low dose, you're probably going to be okay. I think what nobody wants is for something to actually happen and their fertility not be preserved, and then you didn't have tissue frozen. To try to not be in that situation is why we do it, because 200 is better than 400 is better than higher dose, obviously. And so there's no guarantee. We tell them there is no guarantee. It'll probably be preserved, but there's no guarantee. And if we have to use other agents to treat you or whatever, it might become an even bigger problem. So I think we offer it to everybody, no matter what we think their risk is.
Thank you, Dr. Shalini. So due to lack of time, we have to close this session and we have to move to the next session, which is a panel discussion.
And there were some questions that you can always email me don't worry about it, but go on, Satya.
So Sailesh, you can just wind it up and
I think the questions can be taken up.
We can take in the next session. Next session, Gaurav.
No, questions can be taken up in the panel discussion. Yeah, that's it.
Okay.
Dr. Shailesh, you're muted. Dr. Shailesh, you're muted.
Yeah. Okay. Thank you, Dr. Shalini. That was a very informative talk on sickle cell transplants. I'm sure more and more centers, not many centers are doing it in India, but more and more centers would definitely pick up and do these transplants. So with this,
There's a lot we have to learn from you all, because I think some of the things that you see pre-transplant are novel to you, novel to us. Exchange of information is important.
Definitely. With this, I would hand over the session to the moderator. Can you please take over, please?
Thank you, both the speakers and chairperson. And now I would invite Dr. Sunil Bhatt to take over to the next session. Over to Sunil. Thank you.